and pelvic region, you put the person in crook lying position, especially for pelvic complex, because that will be going for a loose pack position. That will go for a loose pack position, okay? So this is the loose pack position for the pelvic complex. And the loose pack position, if you are dealing with the lumbar spine, it should be flat position, flat. The loose pack position for the spine is midway between flexion and extension. No lordosis, no kyphosis, just straight, okay? Just remember this. So now, when there is upslip, take the fast waist space, put it on the iliac crest, okay? Put it on the iliac crest and give the glide, inferior. Give the inferior glide. And inferior glide, you have to give preferably grade 3 mobilizations. So what is grade 3? When you, maybe some of you who know, that is fine, and some of you who are new, maybe I will just tell you. Grade 1, small amplitude, bidirectional, repetitive, rhythmic movement at the beginning of range of motion. Grade 2, large amplitude, bidirectional, repetitive movement, neither touching the starting position nor the physiological barrier. So you see, just observe here. So this is the range, okay? Starting position, my left hand starting position, this is the end position, this is the anatomical barrier. Here there is a physiological barrier. Starting position, physiological barrier, anatomical barrier, okay? Now grade 1 will be here, small amplitude movement. Grade 2, large amplitude movement, neither touching the starting position nor the physiological barrier. Grade 3, large amplitude movement, physiological barrier is here, 50% into the, and this physiological barrier, anatomical barrier space is called as paraphysiological space. So grade 3, 50% into the barrier, 50% out of the barrier. Grade 4, small amplitude movement in the paraphysiological space. Grade 5, small amplitude unidirectional thrust. Okay, so out of this, preferably for this dysfunction correction, you have to give grade 3. If lot of pain, then grade 2. Okay, standard grade 3. Large amplitude movement, 50% into the barrier and 50% out of the barrier. Then how many glides we have to give? Give about 10 to 15 glides. Give 10 to 15 glides. Okay. One method. Come to supine line. Supine. Straight, straight, straight. Come here. Please come. You lie down. You lie down. You come. Lift it up. Lift up your hand. Okay. Stabilize. Stabilize this. You come and stabilize here. Okay. Fine. Next is tug pull correction. Tug pull correction. T-U-G-P-U-L-L. Tug pull. You know the tug of war, right? Tug of war, next time you go for this tug pull grasp. There is a grasp for that. The grasp is this. Thumb in the third waist space. Next time you go for tug of war, hold like this. Okay? Not like this. You may get skin. Other party is strong. Skin ripping up might happen. Thumb, third waist space. Hold it. Okay? Above the ankle joint. Thumb, third waist space, hold above the ankle joint. Okay? Right. Hip is flexed for about 20 degrees, abducted for about 20 degrees. We are keeping deliberately hip in the little loose pack position, so that we can manipulate from the hip. The femoral head will pull the acetabulum down. Now right side is affected. Okay? Hip is flexed, abducted, holding above the ankle, tug pull grasp, stabilize, pull, take up the slack, go to the barrier and give thrust. Give this. So what is the knee is already in close pack position. I am holding above the ankle joint. Knee is already in close pack position. So femoral head in the acetabulum will pull it down. Okay? That is the mechanism. Stabilization is done by somebody else. Hip 20 degrees flexed, 20 degrees abducted, hold above the ankle joint, tug pull grasp, pull, take up the slack, go to the barrier, give thrust. Although for spine we are giving a single thrust, for this we can give 3 to 4 thrusts. Because this is basically a pull happening in the hip joint, but that is pulling the innominate down. So it is one of the very effective method for correction of sleep dysfunction. Okay. The next is muscle energy technique. Now let us understand. Now when there is sleep, the QL, quadratus lumborum muscle, also will become tight. So we need to release it. I told you the principle of Vladimir Yanda earlier in rehabilitation. When you have got imbalance of tightness and weakness in the lower cross syndrome or any cross syndromes, stretch the tight structures at first. Okay. So now it becomes a vicious circle. Which one? There is a sleep dysfunction. Sleep leading to tightness of quadratus lumborum. One. Quadratus lumborum leading to sleep. Okay. So it will become one vicious circle. And in rehab, you find multiple issues of passive component involvement, active involvement, neural involvement. You need not have to wait. You have to strike at multiple places, right? You cannot just for one single approach, one single thrust I will give and it will correct the problem. It never happens. And please don't get carried away with some Instagram video. You have seen that one thrust and all problem in the world solved. Maybe problems begin there. You know, don't take it very seriously. Okay? Now, it is something like this, you can consider it is like one advertisement. Okay? You see somebody that fog, somebody is putting and one boy putting that and 10 girls are running, or one girl putting and 5 boys running. That second may be correct, but fast never happening. Right? So it is something like that. So don't, now if you take it very seriously, you think that one thrust is curing all problems, then you think that there is a requirement of AIMS here, so much of infrastructure government is spending, so many hospitals in crores of investment. So it is not happening like that. Okay, one thrust, I mean, it may make a symptoms may 10-15% better, but that is not going to provide a complete solution. Okay, now coming to this sleep dysfunction, first, superior to inferior translation, second, tuck pull correction, third, muscle energy technique for quadratus lumborum. Okay, now subject in side lying position. One more pillow, can you please bring? No, you don't, you lie down. Bring. Jaldi lao, slow mein la raha hai. Utho. Get up, get up. He do not want to get up, I think. He is the luckiest person among all of us. I am standing, you are still luckier sitting there. He is more luckier sleeping here. Okay. Lie down, lie down. You, okay, 1 minute. So that they can see. Lie down on your right side. This will be in the lateral to your lumbar spine. ठीक है, तड़ो नीचे जाओ, हाँ, सो जाओ, हाँ, okay, fine. You see, I have kept the pillow lateral to the lumbar region. So here, what is happening? We will create a slight stretch to the quadratus lumborum muscle. Okay? Quadratus lumborum attachments to the iliac crest, to the transverse process of the lumbar spine. Right? That is the major attachments. So iliac crest, fingers interlocked, and the iliac crest you pull it down. Okay? Go to the barrier. Already just before some time I told you about the physiological and anatomical barrier. Just to make it more simplify, if I just tell you to understand the barrier, let me just tell you. Now you take your wrist for flexion. Okay? Take your wrist for flexion. Active movement. After active movement, give slight overpressure. Slight overpressure. You get R1, resistance 1, okay? That is the physiological barrier, R1. Move further. R2, anatomical barrier. From this, you want to move further, you will break some structures. Where no possible movements are no possible without crossing the anatomic, structural integrity, that is the anatomical barrier. See, active moment, passive, physiological barrier R1 and this is R2. This space is called as paraphysiological space. So when I am talking about the barrier means I am talking about this first R1, okay. So same, every joint will have that kind of barriers. So subject in side lying position, pillow is kept, fingers interlocked, iliac crest pulling down, going to the barrier. Okay, then I will ask him to hike it. You hike your pelvis, okay, hike it, okay, hiking. Action of quadratus lumborum. Hike it, give only 30% force. Hike, okay, 1, 2, 3, 4, 5, 6. I will tell you what exactly I am doing now. This is the muscle energy technique, very effective technique, but we are recruiting 30%. We are recruiting 30% of the effort, 1/3. Now somebody thinks how to activate 30% and why 30%. This is based on Dr. Charles Sherrington's principles. Okay. There are so many principles of Dr. Charles Sherrington, and what I will suggest to you in this particular lecture is, please go through one 1932 Nobel lecture of Dr. Charles Sherrington. One, as a physiotherapist, you must go through at least 2 original articles. One is 1932 December 7th address of Dr. Charles Sherrington's Inhibition as a Coordinative Factor. The title of that talk or the presentation is Inhibition as a Coordinative Factor. I will tell you one of the excellent lecture I have read, or one of the, and not very easy, although lecture given at nearly 100 years ago, near to 100 years, but honestly I will tell you, it is not at all one easy interpretation of that lecture. But what I will suggest you is, you read it from beginning to end, whether you understand or don't understand. Something you will understand. One thing you understand is inhibition as a very important factor, and that is what we are going to do now. Inhibition. The muscle is overactive, we are going to inhibit it. Okay. Another article you must read is 1965 article by Meljak and Wall on pain gate theory. These 2 articles you must read, and this you can read it today itself. Okay. Whenever you get some break time, you can, all of you are using the mobile phone, maybe you can read it. It will help you a lot in rehab to understand what exactly you are doing. The science of physiotherapeutic practice. Okay, so what is 30%? You can sit down. What is 30%? Now you know muscle testing. Okay, for any muscle 1 to 5, 5 is 100%. 0, 0, okay, great value. 1 is 100%. So now, if I tell you that if you know how to count from 0 to 100, definitely you know how to count 30 also. So that is the answer. I hope you understand my interpretation, what I told you. Now if you know for any muscle, you know as a physiotherapist, if you are testing for my biceps, his biceps, or a child sitting there, one child was there I think, oh okay, she's doing a great job attending a conference, okay, such a young age, fine. So now, and sitting patiently. So now if you are testing the biceps for different people, maybe what grade 5, the force you are giving, for me if it is say 50 newtons, maybe for her it may be 12 newtons, or maybe for somebody it may be 48 newtons, but if I tell you also in Newton, it is not going to help you, right? You are using your, a professional expertise, so that is, or intuition to understand, right? Exact calibration I tell that give 75 Newton of force for him or for madam, so you may not be able to give. So you understood the context. So now you know what is grade 5, and you know that 1/3 of the muscle contraction effort you have to give. Question is why? Because if we give 100%, there is one Sherrington's principle of after discharge. There is a Sherrington principle of after discharge. Maybe थोड़ा टिके बढ़ाई देवे sound टा टिके मतलब टिके stress पड़ुଛି हाँ टिके बढ़ाई देवे हाँ ठीक है fine okay. So now if you give maximal contraction, what is going to happen? More number of motor units are going to recruited. Firing will be there. And after discharge, after you put 100% contraction, the contraction is going to remain for a long time. So it will not going to relax the structures. Okay. So that is why we are giving. And another thing is, if we can achieve something in 30%, why to put 100%? Why to put more effort? Okay. So we need to do one important principle of not only rehab, but maybe personal management is, instead of doing hard work, do smart work. Okay. So do smart work with 30% efforts. Okay. In MET. Subject in side lying position, fingers interlocked on the iliac crest, go to the barrier R1. Okay. Ask the person to hike the pelvis. Give only 30%, that much effort. You can calibrate, you can guide the person. 1, 2, 3, 4, 5, 6. What is this count I am doing? We have to hold this contraction for 6 to 10 seconds. On an average 6 seconds. Then relax. Repeat it for 6 to 10 times. Okay? So this we are now, if you analyze, first step we did the management for passive component, superior to inferior glide. Second step we gave the thrust, again for passive component. MET is for active component, that is the muscular component. Okay. So this is how we manage the upslip dysfunction management. Okay. Next I will show you downslip management. Theoretically existing, practically, because it will not be symptomatic. Once again, different dysfunctions, upslip, then downslip. What is the finding? Iliac crest is down, ASIS is down, PSIS is down. Gillette test is positive. But it will not be symptomatic because it is not causing the irritation. What did I tell you? Out of total 29 receptors, almost major receptors are in the posterior part of the SI joint. 28 are nociceptors, and majority of them, maybe 28, 27, 28 are there located in the posterior part of the SI joint, not in the anterior part. Downslip, okay? Anterior rotation dysfunction. Next, ASIS is down, PSIS is down, and Gillette test is positive. This is very, very common. Anterior dysfunction, upslip, very common. You take any low back case, what I will suggest you is, you get any low back condition, don't just check for, somebody might tell that I am having only, pain here. Check for the pelvic complex. Definitely it will affect the pelvic complex. Another thing what we come across clinically. Patient comes, sir, disc bulge case, I heard 5 years back, now it was fine, but suddenly again before 10 days it has started. See, many times I will tell you, I examine lumbar spine and scan also is there, scan also bulge is there, correct? But they will be showing this area. Not the lumbar spine, they are showing right side, specifically SI joint. I am getting the pain over down, going down and this thing. So, sometimes MRI finding is there for a disc bulge, but disc bulge clinical presentations are not there. You palpate lumbar spine, there is nothing. You palpate pelvic complex, lot of changes. Even in, so every time we need to clinically correlate. I hope those of you who are in clinical practice, you can very well understand what I am trying to tell you. Now somebody with a neck pain, X-ray you take, as age of 70, a lot of osteophytes absolutely doing fine before 5 days. Just 2 days back, suddenly the pain has started. You see that and you correlate that is due to these osteophytes and all. No, the osteophytes started nearly 20 years ago. So it is something like this, that there is a coconut tree. In Upanishads we get these descriptions. There is a coconut tree is there and the crow flew and the coconut fell down. You understood the condition? Coconut tree is existing. Coconut, you just saw coconut fell down and the crow flew. So you correlate the coconut fell down because of the crow. So I will leave your analysis to you to think. So similar situation, okay? So definitely the crow was not the cause of the coconut fall. Coconut fell of its own and both are independent factors. So you should not just merge it, okay? So these are aphorisms we find in Upanishad thoughts. Okay, now in this upsleep dysfunction, downsleep, anterior rotation dysfunction. ASIS is down, PSIS is up and Gillette test is positive. Next I will show you the management for downsleep management and anterior rotation dysfunction management. Come to supine. Supine line, yes. Get up. Come to crook line, crook. Right. So downsleep management, I have not come across, but if you, in case you come across any time, so subject in crook lying position, as I told you, that is the loose pack position of the pelvic complex. Make the fist, place it in the ischial tuberosity, okay? Place it in the ischial tuberosity. Give the glide upwards. Mobilize and give a thrust. That is in crook lying position, one. Another one, you can do it in prone lying position. Subject in prone lying position, make a fist inferior to the ischial tuberosity, glide. As I told you, you have to give mostly grade 3. Then if you are able to give the grade 3 comfortably, give grade 4 and at the end give a thrust. That is how you have to manage the downsleep, okay? Come to crook line, okay? Making a fist, placing it inferior to the ischial tuberosity. Just now I showed, okay? You can do the reinforcement. Go to the barrier, first check for the barrier, mobilize, then give the grade 3 movements, then grade 4, about 4 to 6 and then give a thrust. Mobilize, thrust. Come to prone line. For downsleep there is no much of active component managements to do. Come down, come to the side, okay. Hip is flexed, prone lying position. Abducted, ventral aspect of the palm inferior to the ischial tuberosity. Go to the barrier, mobilize and give a thrust upwards. Okay, come to supine. Next, coming to anterior rotation dysfunction. This is very, very common. Upsleep and anterior rotations are very common. Anterior rotation dysfunction, ASIS is down, PSIS is up. Okay? Gillette test is positive. Okay? Now what it is going to do? It is going to irritate the, and there may be combination also. Problems can be in combination. Upsleep, anterior rotation dysfunction. Upsleep itself is going to compress the SI joint and anterior rotation is going to create more stress. You see what is happening. Neutral position, upsleep, getting compressed, anterior rotation is going for more shear, more compression, right? So coming to anterior rotation dysfunction management, come to crook line. As it is anteriorly rotated, ASIS is down and PSIS is up, apply the posterior rotation. So how to apply posterior rotation? From the inferior part of ASIS, place the PC form, and apply the force posterior, superior and lateral. Go to the barrier. It is not a plane vector. It is a resultant of the vector. You see, it is not like posterior, superior and lateral, not like this. It is a curved. You imagine there is a football and you are trying to roll it. Okay? That is the direction of force. Apply the force posterior, superior and lateral. In other words, towards the ipsilateral elbow. You put the elbow in the side, towards the ipsilateral elbow. PC form, inferior to ASIS, apply the force towards the ipsilateral elbow. Go to the barrier and mobilize. See, I am giving the grade 3 mobilizations. Give only mobilization. We have a separate thrust technique for this. Very, very effective technique. Get the in a minute. See here what exactly is being done. Inferior part of ASIS, force is applied. See, I am moving also. Posterior, superior and lateral. So that the anterior rotation is getting corrected. One thing. As I told you, it is not a single method we have to apply. We have to apply multiple methods. Okay, one is this. Second is, come to supine lying straight. Thrust technique. Very effective technique, otherwise called as Chicago technique. Okay, subject in supine lying position. Every step is important. Lower extremities are crossed. Affected side is kept up. Now, we have one involvement in the, say in the left side, and in anterior rotation it is going like this. ASIS is down, PSIS is up. Okay. Now, lower extremity is crossed, upper extremity is crossed. Lower extremity is crossed, affected side is kept up, upper extremity is crossed. Next step, create the convexity in the side of involvement. You have got left side involvement, convexity is created in the side of involvement. Sometimes what happens, when you are doing these procedures, the patient might try to help you. That creates the biggest problem. Patient helping you to do the positioning, and while doing that they will alter all the things. I tell that the best cooperation what you have to get from a patient is you ask him or her to, Madam, sir, please lie down, relax, rest, I am doing the procedure. Otherwise it will lead to disturbance of your position. Okay. Now, lower extremity is crossed, affected side is kept up, upper extremity is crossed, convexity is created, trunk is rotated to opposite side. Now we have got involvement in left side, upper trunk is rotated to right. PC form is kept inferior to ASIS. Okay? Go to the barrier, right? Go to the barrier and give a quick thrust. Barrier and thrust. Sometimes you will get cavitation, sometimes you won't get cavitation. But the researchers tell whether you manipulate, if you get cavitation or you don't get a cavitation, your results are the same. Okay? Just come here. I will tell you the difference what we achieve when we do mobilization and when you do thrust and when you do in combination. One simple positional logic I will explain to you here. Say this is the original position of structure. In manual therapy, what is our objective? What we exactly do? We are positioning the structures to their original structural and functional optimum position. Right? Now, in a way, we are discussing about the pelvis SI joint. Now, if it is anteriorly rotated, we are putting back the structures to its original structural functional optimum position. Because any deviation is going to create the problem. Right? Now, say this is the position of a structure and it is displaced, say, for here. Now, this is the original position displaced here. Okay. See, when you mobilize gently, what exactly happens? When you mobilize, that is the position. When you mobilize, we do some movements like this. Now, we have placed it. Right? When you manipulate, what you do? When you give a thrust, be prepared. When you give a thrust, you give a movement like this. But when we give combination, this is what we do. Now you tell me, giving suddenly one thrust is one aggressive maneuver for the structure. This is what, so structure may not be ready. You can give a thrust provided the structure is ready to take it. Otherwise, it will be chaotic. Especially, there are, some 5 years back, I gave one talk in AIMS Delhi conference related to adverse effect of cervical manipulations. Lot of documentations of even stroke and death cases, and I'll share one of my experience 3 months ago. 3 months ago, why you have to be cautious to give the thrust techniques if you are not a prepared therapist and the patient is not prepared. It will be chaotic. That is why I am telling you in advance. Okay. Now, incidence goes like this. 3 months back, I got a call from Bombay. That person telling me that one 27-year-old IT engineer working in Bangalore, he had some neck pain. Some urban clap app is there. I have never used that. That person used some urban clap app and called some person to do some massage for him. And while doing that, that person has given some thrust in the neck. That time no problem. After 2 days, he had difficulty in speech and weakness of upper extremity. Going to the neurologist, then treatments, then that is why the person called me up, sir, we want some improvements, proper physiotherapy so that he recovers. I mean, what I am trying to tell you is, 27-year-old IT engineer having this kind of problem, you understand it is one irresponsible, somebody has given just somebody might have seen some reel somewhere and giving some thrust. So please don't do all those things unless and until the structure is prepared for. This is how it reacts. Okay, fine, you can sit down there. Well, this is a good technique. You mobilize it, this thing, nearly 30-40% of relaxation has happened, structures are ready, no, lot of spasm is not there, joint is also ready, check, then you can give a thrust. So from there, you know, that is more wise of doing the management. Crook lying position. Again, he tried to help me. You saw what happened? He tried to help me. He tried to help me now. He distorted the positioning. Okay, fine, no problem. Straight. He helped me actually. He helped me to make you understand. Huh? Lower extremity is crossed. Left side is affected. Upper extremity is crossed. Again, don't try to help me. Okay? Create the convexity. No, his intention is good. Trunk is rotated to opposite side. PC form. Inferior to ASIS. Take care of your positioning. Always, when you do these procedures, take the wide bend stance. Don't stand in one place. Ensure that your spine remains straight to the maximum possible. Because your spine bending can create some stress to your spine. So you take care of, in flight they make the announcement, no? Before taking care of others, take care of yourself first. Mask yourself first before giving the mask for others. Same thing. Rotate, barrier and give a thrust. Right? So this is the Chicago technique. Next technique is the muscle energy technique. Come to crook line. MET for anterior rotation dysfunction. So here we are going to use the force of the gluteus maximus. Okay? We are asking the person to take the hip for extension and we are resisting it. So the gluteus maximus, instead of when we are taking the hip for extension, gluteus maximus is moving the femur, right? Now what happens? The femur is stable. We are making the femur stable. Muscle is contracting. So instead of moving the femur, it will move the innominate for posterior rotation. That is how it is a very, very effective technique. Very effective and very safe technique. You find anybody with increased lordosis, lower cross syndrome, anterior rotation dysfunction, spondylolysis, spondylolisthesis cases, you can apply this technique. Very useful and very safe technique. Okay. After this, subject in crook lying position, forearm, place it at distal posterior aspect of the thigh. Okay. And you are taking some support here from the opposite knee. Ask the person to do this. Okay. Hip extension. Give 1/3 of efforts. Okay. 30%. Press down. And you can tell, give little bit more force, you can calibrate. But as a physiotherapist, your understanding is that we are going to recruit about 1/3 of the muscle contraction. Down. 1, 2, 3, 4, 5, 6. Holding it for how much time? 6 to 10 seconds. And we are going to repeat for 6 to 10 times. Down. 1, 2, 3, 4, 5, 6. Relax. Okay. So this is the muscle energy technique. Okay. Along with this, what you can do is, you can activate the core. You can do the core activation. Right. So what is the core activation? There are a lot of techniques for core activation. One of the very effective technique for pelvic complex for the SI joint is tabletop. So tabletop. When you do the tabletop in core, there are two methods. One is bracing method. Another is tuck-in method. Bracing method, another is tucking in method. The bracing method is more better as far as the ultrasonographic analysis. Because when you do the bracing, and if you see the ultrasonographic scan in bracing method, the transversus abdominis, the fibers all will be remaining parallel. They are not going to intersect. Whereas when you tuck it in, हो गया time? 11 बज गए?
Thank you, Umasankar sir and Narendra sir. We are going to resume the session with Umasankar sir and Narendra sir after a vibrant dance performance.
So we are taking one break as far as the schedule, and then we will be continuing. So there will be a dynamic cultural program. Okay. That is how Mona Madam has arranged the program. So Madam, I will continue after. They